month. This is the last series of this month of 2023. And today's theme is trauma in Ilizarov. So we have a very renowned faculty from Egypt, Professor Fadel, who will be talking on his important, very, very important lecture. So without wasting time, invite Shamsul to give a brief introduction to him, and we'll be hearing the talk then. Shamsul, please.
Yeah, thank you, sir. Thanks a lot, sir. So, very good evening to all members. We just welcome you again in our series of master class of webinar of Uttar Pradesh and Uttarakhand chapter, and that is on Ilizarov and trauma. Today we have eminent international and national faculty. Today we have the renowned Egyptian Professor Mohammed Fadel from Limb Reconstruction Society, Nasr City, CAIRO, Egypt. He'll be talking on orthoplasty, Ilizarov assisted technique in long bone trauma. We have our loving Dr. RAJAT AGRAWAL, President, Asami, India. He'll be talking on primary management of compound fracture to Ilizarov. Then we'll be having case discussion by Uttarakhand team, very good surgeons, renowned surgeons. We have Dr. MOHIT DHINGRA from RISHIKESH, Uttarakhand AIMS, and we have Dr. Major RAJEEV from DEHRADOON Army Hospital. So let's talk about Professor Fadel. Is working at Minia University Hospital, Alminia, Egypt. He's at LRS Center, Nasr City, CAIRO, Egypt. He's executive board member of EOA, European Orthopedic Association, Limb Reconstruction Surgery and Correction of Deformity Center, LRS, Nasr City, CAIRO, Egypt. Consultant of LRS in Adults and Pediatric Orthopedics, Minia University Hospital, Alminia, Egypt. Executive board member of EOA, active member of CCOT Computers and Enabling Technologies Subspecialty, committee member, CCOT Infection Subspecialty, Director of Africa, Buyout Director of Africa. Recently, in 2022, we had a wonderful meeting on Buyout CAIRO, which I attended. His WOC Vice President, Founder and Program Director of LRSPD, member of Asami International, Asami Egypt Board Member, Founder of Egypt Arabs and LRSAA, member of IFPOS, POA, member for ITM website. His Founder and Program Director of Professional Diploma in Limb Reconstruction Surgery and Correction Deformity, which have been a faculty also. So it's a very interesting online and physical courses organized by FADEL, sir. These are his contact emails and website. There's a list of publications there in OSID. This is a website link. You can see the different logos. He has been associated with so many organizations, heading at Egypt and Arabs and various programs. His work as a research also. He's the chairman of Scientific Committee of many international conferences in Egypt, chairman and member of Scientific Committee and the International Course of Skeletal Deformities Correction, and chairman and member of Scientific Committee, Annual International Congress of the Egyptian Orthopedic Association, co-secretary general of 57th Annual International Congress of the Egyptian Orthopedic Association, chairman and member of Scientific Committee, EUA Annual Conference, moderator of many international symposium abroad, like fourth meeting of Asami International at Kyoto, Japan. He's been a moderator in the session with many other renowned faculties like Hiroti Shikeya, James Binsky, Kevin Louis, Takashi Matsushita, member of Scientific Committee of many international conferences like CCOT PAOA Dubai, CCOT India, Hyderabad, 42nd Pan Arab Medical Congress, Amman, Jordan, POA Jordan, POA Oman, POA Yemen, POA Morocco, KSA International Conference, King Saudi Arabia, and Asami Poland, Asami Kyoto, Asami Russia, Asami Egypt, Asami Greece, Asami India. He's a member of Scientific Committee of many international courses, Jordan, POA, Yemen, and Oman. So today he'll be talking on orthoplastic Ilizarov assisted technique in long bone trauma. Over to you, sir. Others, over to you, sir.
Okay. Is it okay, Ashok?
Yes, sir. Visible, sir. Please start.
First of all, thank you so much My topic today is about orthoplastic Ilizarov assistive technique and long bones trauma. Thank you, dear friend, Dr. Shyamsul Hoda, about this introduction. I am not in need to present myself more again. And I would like to present my thanks and gratitude for all the committee members of Asami, India, especially Dr. Rajat, Dr. Ruta, Dr. Jayant, and happy to share us with some promising stars, Dr. Mohit and RAJEEV. It is a very nice idea to have all new generation. I am sure that I will enjoy by their presentation. Our history with cooperation is long time ago. I think I still remember in 2021, during the era of COVID, at those time we enjoying the presence of our colleagues, our friend John Janwala, Ruta, Shamsul Hoda, Ravi, and Rajat, Christian and Jinendra. All of them, actually, I enjoyed with them with many meeting webinars in that very bad time. Actually, I'm honored in many national and international association. I would like to present on behalf of all these societies our respect and our cooperation in advance in any time we are in need to cooperate with each other for the sake of our trainee and our patients. We just finished the CICOT and Egyptian Orthopedic Association conjoint meeting. It was fantastic. I met many of my friends and colleagues from India. Unfortunately, I missed to meet one of our Asami board, but later on we will try to be more organized to have you all. Conflict of interest. Actually, I have a conflict of interest usually I would like to share anything related to Asami India. Actually, this is my conflict of interest. My aim is this topic. I will try to divide it into 5 minutes, 5 minutes, 5 minutes, and so on. Try to cover an aspect. I know that you are all working in this aspect, but I would like to name it or to propose a name for what we are doing in our practice by using Ilizarov concept and apparatus. But I hope that my project of nomination of this technique, which collects, and it has happened but without name, but I would like to suggest for you this name. I used it to do and present it maybe 8 years ago. So we will try to talk about definition of the orthoplastic principles, what is the meaning of orthoplastic principle generally, and its effect on the long bone trauma. Looking for the definition starts since 1993 by Levin. Levin presented that the concept consists of principle and the practicing of orthopedic and the plastic surgery applied to clinical problem, either by a single provider or team of providers working in concert for the benefit of the patient. This is, at that time, this is the concept and this is the definition of Scott Levy. Also, in after 1993, he presented an editorial lecture talking about this concept in reconstructive soft tissue defect in foot and ankle. And he mentioned in this editorial in 2018 this definition again. At the time, Zoran and his colleagues tried and make some disagreements that the definition and the history that had been presented by Scott Levin is not, to some extent, go in compatible with their knowledge, as they said that they used to work with the well-known name Marco Godina since 1977, so that they say that two surgical specialists, orthopedic and plastic, had been invented by Godina at that time. Letting this understanding between Scott Levin and that one of Godina. Also, reconstructive microsurgery, Banayoti and Mavroginis in International Orthopedic talk about the reconstructive microsurgery. Andreas and Banayoti said that orthopedic surgeons and plastic surgeons both specialized in microsurgery. So there is a cooperation, or there is a matching between all these three subspecialties. And they consider that microsurgery is a specialty with significant overlap that plays a critical role in advancement and improvement of surgical outcomes with the development of orthoplastic. So the orthoplastic is maybe orthoplastic, orthopedic, and orthoplasty, and also microsurgery. The ideal is such in this case, looking for this a child, open fractures, grade 3B, as we will see here. In these cases, they usually would like to be an orthoplastic scale S2 in the same session, concomitantly in the same time, to apply XFX monolateral and apply the plastic surgery in the same session. This is the usual or the conventional orthoplastic vision of the orthoplastic surgery. For ourselves in Egypt, we started 2015 by Chicago Foot and Ankle Deformity Correction Center with Rodriguez, and started to the implementation of the orthoplastic skills to have some benefit of this as orthoplastic. So we are indulged in this since that time, and we consider that though known, but it is not to some extent had been practiced but by many of us. So looking for our problem, which is trauma and post-trauma loss of bone, massive bone loss, and or following infection, we are in need to deal with a bone defect of different sizes. In these instances, many techniques present solutions for such problems, and the specific methods of skeletal reconstruction of massive bone associated or not with soft tissue remains a controversy need for a solution. So we met many of marvelous flow charts, or what is called algorithm, for management of these bone defects post-traumatic, and one of them is related to our friend Rodriguez. And I am also usually following up your activity, and actually appreciate this too much of take caring of trainee and LRS in Asami, India. Looking for the defect, according to its massive presentation, we may have main blocks of management, either to use vascular technique, free microvascular bone transfer, vascularize the free fibular graft, or the malvarous procedures of distraction osteogenesis, or what I would like to call it, Ilizarov assisted technique in management of severe bone defects. In these instances, we may use fibula, Ilizarov technique, may use bone transport, or the most last salvageable procedure is to use salvage fibula Ilizarov transfer in leg, using also the method of distraction osteogenesis. So I would like to introduce the terms of orthoplastic Ilizarov assisted technique scenario. As a review for what we would like to do in case of bone defect, either to use a bone graft, which is well known for all of us, non-vascularized bone graft, but it is recommended to use in patients less than 5 centimeters, and not recommended in those using non-vascularized bone graft in defects more than 5 centimeters. Sometimes looking for the SS sites that some authors recommended that 2 cm as a maximum size of segmental diaphyseal tibial defect should be managed with autologous cancellous bone graft. Especially in some cases, we may have both sacroiliac joints had been sacrificed in a previous operations to reconstruct post-traumatic infection or post-traumatic bone defect. So we sometimes need some application and some modules of cages, or to use non-vascularized fibula transferred to the other side or for anywhere as we'd like, especially for the upper limbs. Using the vascularized bone graft to substitute this bone defect, it is beneficial, especially in cases of infection. At that time, there is a lower risk of post-surgery infection. But the bad thing is that the low grade of tibialization of the fibula in these instances, and the need for long time for consolidation proximally and distally. So Ilizarov is suitable in many instances to keep the patient walking while he is waiting for full consolidation of the case. But in all these cases, actually, we prefer to consult our plastic surgeon if we have, because in many instances we couldn't have. And if we have, we couldn't rearrange and make this combination of work to be concomitantly in the same site, in the same session, in the same ward, in the same hospital, or in the same institute. And in all instances, we found that the problem at last or from the start will be on the shoulders of the orthopedic surgeon. So we're trying to usually save this by doing all these things by ourselves as an orthopedic surgeons. We are looking for muscular technique also as a marvelous technique for replacement of long bone defects, which is of variable sizes and maybe going up to maybe 20 centimeter as mentioned by Muscular himself. Some orthoplastic effect of Ilizarov assisted technique is just to do simple shortening. Simple shortening solves the problem in many cases, especially those of high demanding or those who are not amenable for long surgery or for a long time of apparatus to do lengthening, and who have immunosuppressive disease, or for those of old age that have so few activity or social demand. Shortening and angulation had been used, and in our opinion, this is one way of orthoplastic effect of Ilizarov. You can make angulation to stitch the skin or to close the skin or even to sutures the tendons, and following the healing of the soft tissue, even 2 weeks later, you can do this repositioning of this in a straight way again. So it is also, in our opinion, an orthoplastic effect of Ilizarov. We are doing this, but we couldn't name it. We didn't name it as orthoplastic Ilizarov assisted technique. Also, lengthening in some cases, if more than 3 or 4 centimeters, can be managed and can be dealt with either with monolateral or Ilizarov, as mentioned in the previous slide. The other marvelous effect of orthoplastic effect of Ilizarov to do bone transport that carry with it the bone, not on the bone only, but also with it carrying the soft tissue and muscle and the subcutaneous tissue. Also, this is slide controversy for dear friends. I presented a lecture and one day of workshop in Nigeria. Our friend Okunola, who is the president of Asami in Nigeria. I am honored also to remember this last activity of Asami India. Thank you for you all for joining us and for our cooperation. As I mentioned, consultation of the plastic surgery and the need for cooperation is mandatory, but looking for these our trials to listen and to watch and to try to learn from Rodriguez and Suhail in a cadaver dissection lab in Cairo. We try to master this technique of microvascular and transportation. We will see how this piece of fibula will be taken and doing very efficient recovery of a piece of bone, either tibia or fibula. So I relied upon Ilizarov assisted technique, as we are all doing this, but we didn't name it as Ilizarov assisted technique. And this is returned for the godfather of this direction, histogenesis, Gabriel Ilizarov. This principle of tensile stress, it worth to mention it again. It is a gradual traction on living tissue, create stresses that can stimulate and maintain the regeneration and active growth of certain tissue structures. This is the definition of the gradual tension, a gradual traction, or the stress or tension stress theory. So I would like usually to use orthoplastic Ilizarov assisted technique in some instances, and we relied upon the versatility of Ilizarov itself to do many things, either in trauma or post-trauma effect. This is the view of the use of Ilizarov in many years ago, had been known so long time, but the problem is usually how to maintain this for a long time without keeping the patient in bed or restricted of movement. This is the marvelous effect of Ilizarov. We can do this technique by using a fibula without all these technical demands of knowing many things about microvascular to do a cut of fibula in this way. So in planning, we are in need to assess our patients. If we are in need to do for them a reconstruction, we should restrict these techniques of orthoplastic using fibula, especially for massive bone loss, and in cases of vascular compromise, and in cases of short tibial remnants, either proximally or distally. So for looking for a patient with a bone defect, post-traumatic or either post-debridement with extra problems such as non-union or a stiff knee or a stiff ankle, for such a case is an example for what we'd like to call it orthoplastic Ilizarov assisted technique. We can see here how it was an open fracture, had been fixed by monolateral external fixator that had been resulted in loosening and severe infection that need to be resected and apply what? For the classic orthoplastic, we are in need to do microvascular resection of the fibula to tract even this piece or more longer to be in this area by microplastic scales, which is not being available in easy in any orthopedic system in any hospitals, in most of our hospitals. So the term of salvage fibula Ilizarov transfer as an orthoplastic effect, that I would like to present it as an introduction for using Ilizarov assisted technique on solving these conditions. It works well for doing this condition, and for those skeletal reconstruction of massive bone and soft tissue loss, it is remain a topic of controversy, as we said, but also a topic of compromise. It is not usually a honeycomb. It is usually full of some problems. It is not simple for the patient to have a fibula instead of tibia, and to have this small bone instead of this wide triangular cross-section bone. So for those patients who lost or couldn't have this conventional management of bone transport, we look for salvage use of fibula to transfer it is an orthoplastic effect, which is beneficial. As in this condition, as I show in a hurry the previous case. The first presentation was past history of comminuted fracture tibia, infected, external fixation had been applied by ionoplanar 1, as we see here, with a good position or acceptable position for an early emergency room, but later on we can find that there is unstable because it takes long time until the final definition. There is outpouring pus, necrotic bone comminution, severe pen tract infection and loosening of the pens, which everything here becomes sclerotic as we see here. So we ask and consult ourselves and start the removal of the external fixture, debridement of the bone and soft tissue, and even the Schanz screws penetration or Schanz screws reaming for these osteomyelitic penetrations, and apply antibiotic either systematic or locally. This is a clinical view after few weeks of removal of the external fixator, and then we apply, after we have cleared everything, we apply excision of all this sclerotic bone, and redebridement again, we removed around 15 centimeter of the bone. After removal of more than 15 centimeter of the bone, with application of antibiotic local and systemic, and 4 weeks later, at that time, no infection, clinically, laboratory, we going again for the operating room to do what we think about using the fibula. We try to use the fibula, but by the idea of Ilizarov assisted technique. In this case, we apply proximal construct and distal one, and in this distal, it is too short to the foot, but this is too long because we plan to replace the fibula to be in between these two remnants from the distal one and from the proximal one. So application of the percutaneous wires, as we will see later on. From here, we apply just 1.5 centimeter and 1.5 centimeter here to do corticotomy of the fibula, and here to do corticotomy of the fibula distally, and the fibula itself, before doing a corticotomy or complete the corticotomy, we apply olive wires, 3 olive wires, and from this one, above this proximal one, we do corticotomy of the fibula, and below this distal one, we do corticotomy of the distal wire, and at last, after application well of these 3 wires, and attach it to the side plate here, attach it to it. At that time, we do completion of the corticotomy above and there to have this view. And this is the case if we think of doing microvascular technique. If we look for here from the lateral view, we can find that it is a semi-invasive technique or mini-invasive technique 1, and the direction of the wires should be from posterolateral to anteromedial, and it is clear here from the image that here before doing the movement, here just corticotomy above and just corticotomy distal, as we see here, corticotomy above and there, and this is a 3 wires, and this is the tibia had been resected from the necrotic part and ready to accept this movement of the fibula. As we see here, the movement may be obstructed by the proximal. So in this case, we can do distraction of the distal block until we have this room amenable for accommodation of this fibula. This is an intraoperative image had been taken, and this is another shape. Looking for the movement, we should refer to the atlas and check for this area as we will transfer the fibula. It looks from cut 2 up to cut 5 or early than this by few centimeters. We should put in our mind this direction in this place to be from posterolateral to anteromedial, not direct lateral at all, not anterior at all, but is from posterolateral to posterior. In this way, it looks safe to make some pressuring here and have pass all this area to go for the tibia, which is accepted space in the longitudinal one. So This is as we think from posterolateral and medial, and this is direction which is an important step in the operation. This is after application. This is the system of traction for the side plate. It looks like this from, it looks ugly, but it works well and no problem at all. It is anterolateral and anteromedial, which is not disturb his feet. This is the shape as a coronal one, or from end on from the tibia. During follow-up, we can start here working, and we are in need to push this to anteromedial. And this is clinical photo while we are doing our journey. Now we are approaching the tibia and started to have what looks like Y shape or V shape. And the soft tissue, as we see here, not compromised at all. Here is the journey until in EP and the lateral view, we can find that moved. This is in EP and lateral view. In EP looks like V shape or Y shape, and in the lateral view, it is in continuation with the tibia. Follow up just before removal of the apparatus, and this is how we bypassed all these massive and comprehensive expert system of microsurgery or orthoplastic or plastic surgeon who would like, or microsurgeon, to help us by doing this by ourselves as an orthoplastic Ilizarov assisted technique surgeon. This is how it looks clinically later on, and this is what we have. Video, no time for this, and this is how it looks. As a conclusion, I would like to put in our mind that all of us working with Ilizarov assisted technique, but I hope to admit this idea of orthoplastic Ilizarov assisted technique while we are confronted with a problem of need for and microsurgery or orthoplastic colleague. So orthoplastic Ilizarov assisted technique is our mainstay, and if we would like to add fibula, orthoplastic fibula Ilizarov assisted technique, it works well, especially as a salvage procedures, and this method need some compromise with the patient, as the fibula, although it is valuable in post-traumatic bone defect and the management of bone defect, especially in non-union and infected non-union, and in cases of minimal remnants anterior or proximally and distally, it is valuable and more important as procedures, and may replace, if it is not possible, it can replace trifocal bone transport or vascularized or use of non-vascularized or muscular technique, which needs a long time. But it results in a leg support and walking in simple orthosis. The patient should know that he, for a long time, he will use an orthosis to safeguard from vigorous activity, and also mobilization should be reduced for some extent until hypertrophy of the fibula in some cases. At last, I would like to remind you that WITE, World Against Infection, Orthopedic and Trauma Congress, it will be held in Miami next September in 2024. I actually welcome you all to share us there. Thank you, and I hope that you accept this suggestion of Ilizarov assisted technique, orthoplastic Ilizarov assisted technique. Thank you.
Thank you, Dr. Fadel, for your wonderful talk on managing the bone defects by the fibula transfer. It's one of the great procedures, and by the method and the technology you show it, I think many of us will be motivated to do it. So one question is, what is the average Ilizarov time in union? Usually your patients, with your patients, what is the average Ilizarov time?
In this case especially, it goes well actually, because we have what shapes like V or Y shape, and the patient, as we see, is slim and average weight, so he stick to have the custom made what is, we know it before a long time, Sarmiento just Sarmiento orthotic, which looks like PTB. So after feeling that the place of the proximal and distal docking site for the fibula, which could be judged clinically and radiologically, which in this case it takes around 7 months. But he take, as you know, his all activity walking from the first day, as we know all. This is a marvelous effect of Ilizarov. He can go out of bed after recovery of anesthesia. He can go to bathroom, which is he can go for every social activities. This is the benefit of Ilizarov assisted technique, which is marvelous and not comparable with by any mean, by any technique that to use Ilizarov as adjuvant in such cases. Actually, no need at least for thrombolytic drugs or aspirin or Vaxato or all these things to take care of DVT.
Okay. Okay, thank you, sir. Thanks a lot for your marvelous talk.
Welcome, dear. I know that you did more hard and complex cases than this.
Sir, may I ask a question for the young surgeons? Fadel, sir, can you hear me?
Yes, yes.
So, what is the rate of transport of fibula to the tibia and the slotted rod, sir?
Excellent. This depend upon the 1 millimeter, as we know, per day.
Right,
this is the safeguard. We can go through this transportation, but in these cases, as you are pushing the muscle, and it is not a wide distance, it's just maybe 2.05 centimeter, around 25 millimeters. So this can be passed by maybe 5 weeks or 6 weeks. So you can do 75 millimeter per day to safeguard any unexpected complications, either to have low regenerate, as we know that fibula is too weak of doing transverse rail or transverse tail to attach as it is for the origin. So I didn't rely upon the fibula to the tibia only and leave off the tibia, but I relied upon the V shape to keep the fibula in contact with its root and have the fibula continuation with the distal part. So I have what looks like Y shape. So this, in my opinion, give me a chance better many times than to make it transverse direction with loss of the continuation with the mother fibula. I find that 75 or 75 3/4 of millimeter per day is suitable for doing this gradual and not gradual. You can say that more slower than usual to keep this attachment or this umbilical cord with the proximal part of the fibula.
That is a very good observation, sir. One more question. Do you do some sort of compression or docking after transport is over?
I did this for the distal construct,
yes,
but for the proximal, I left it to the last days of removal. For the distal part, it is clear for me because it is the tip of the fibula in a wide-based area of the tibia. But for that one, the proximal one, I keep before removal of the apparatus by around 4 weeks to do dynamization, not compression. Dynamization works well in most instances, as I have a continuation with the mother fibula and a new docking site in a very good cancellous bone of the wide-based proximal tibia. So it works, I think, maybe give some advantage this Y shape of fibula, not end to end, but we can call it side to end.
Right, sir. Next question is, being fibula thin bone, what is your weight bearing protocol? Do you allow full weight bearing or partial weight bearing, sir, in the rings?
For weight bearing, actually full weight bearing as he can tolerate. He had crutches to safeguard him from slipping, from walking in a hurry, and even for the street or even for any open walking area. So crutches help him and announce that he is in a rehabilitation area. But actually in his home or in his own area, he usually behave, as he told me, most of them, by what is called like step and dip for the one that it had Ilizarov. He used it to walk in caution outdoors, but in his house he can walk easily without crutches.
Right, so my last question is, sir, what is the post ring removal bracing protocol, sir? Any brace you apply for some time?
It is very important to note him and to have consent from him, even politically, that he should know that you are now relied upon just a fibula, not tibia, and you will be in this orthosis for all your movements, such as you can say socks of DVT. You wearing it as a glass, if you have a glass. So before getting down from your bed, you should put your orthosis. And this orthosis, it is not too ugly. Actually, it looks like PTB, and it looks like a barrel of cast, but it is not cast. It is the thermoplastic cast, thermoplastic sheet, which is applied. It's too light, not heavy at all, and also poured, and with Velcro strap, you can use it to just support and working on pre-tibial PTP, pre-tibial bone tendon transfer. The weight is transferred to the above the tubercle and that around the ankle joint. This is a simple one. If he can take it as a ready-made and he have financial support, he have many types of these orthos.
Right, so thanks, sir. So any risk of neurological complications regarding the peroneal nerve, sir, while transport?
Actually, I'm lucky, and the patient also is lucky. No problem with peroneal transfer, even vascular. I try to rely upon the important thing is that we should go through from posterolateral to anteromedial direction, so as not to cross behind the interseptum between fibula and tibia, or to cross in front of it. We should rely upon pushing the muscles and have the way by pushing the muscles posterior to the interseptal vessels and fascia.
Yes, sir. Thanks, sir. Any more questions for the panel? Dr. Mohit.
Yeah. Good evening, Dr. Fadel. It was a really nice talk. Yeah, it was a really nice talk. Just one or two questions regarding this fibula. When we are doing an osteotomy of the fibula, are we cutting the periosteum also along with it to transport for easy transport towards the tibia, or we are sparing the periosteum of the fibula?
Actually, also an experienced question. Thank you. Actually, I used with it minimal invasive technique, but I incise the fibula post exposure of it and putting bone levers and periostal elevators, levering of the soft tissue, and then periostal elevator, and then application of both hormones, and do drilling, low-grade power drill, and it is better to be with the three wires or three drawing wires that will push. So I should put the three wires with olive for the fibula before doing the corticotomy, either proximal corticotomy or the distal one. But the same technique as the tibia, skin, soft tissue, and then the muscle splitting by blunt hormone, and periostal elevator is scalpel to cut the periosteum, and drilling, and following drilling osteotome if in need to fracture the proximal. And for the distal, the same thing.
Okay.
We have Dr. Jayan, Dr. Umar, Satish Nashi, sir. It's already question, sir.
Shamsul.
Yes, sir, please, sir.
Hello, Dr. Mufakkar.
Hello. Ah,
You just arrived from Cairo.
yes. Can I pass comment? Can you hear me?
Yes,
Yes,
very
sir.
well.
Thank you very much, Professor Fadel. We had a very good time in Cairo, this Code conference, and I was lucky that I had the 3 papers, and out of that, one was this, OPIAT, fibula bone transport after post-trauma, especially gastro 3B, and tumor resection, and big bone defect. And I must congratulate Professor Fadel that he has shown nicely, and there are lots of variants of fibular transportation. And he has shown nicely. Sometimes we do the fibula middle dissection, and just we transport the part of the fibula, including this whole fibula, or part of the fibula means you do a longitudinal split of the whole fibula, the defect, according to the size of the defect, and then you can gradually transport by putting the olive wires in the middle of the tibia, depending upon your defect. This is what, there are lots of variants of fibular transportation, lots of variants.
Yes,
and lots of variants. And this is a
Yes,
fantastic technique and marvelous technique that you should nicely, and you nicely mentioned. And when I was addressing, the hall was full, and one of the presenter asked me the question, why you are not going for the amputation? Then the chairman who was sitting, he was opposed that questioner. Why? You have got this OPIAT, while go for amputation. If you do the amputation, think about the patient at night. If he is suffering with some other diseases, whenever he is going to the toilet without his leg, and what will happen? This was the answer. So my suggestions for the young orthopedic surgeons, and what Professor Fadel showed, this is the best treatment for long bone defects. You don't need to go for amputation. Amputation is not the solution. You have a very good Ilizarov effect that you nicely showed. And this is my observation. And thank you very much, Professor Fadel, for showing your case. Thank you very much again.
Thank you. Welcome, dear friend. And also, I am happy that you shared us. And I miss my dear friends in the Asami India board. Inshallah, next time we will meet and try to arrange this. And agree with you. And also, I enjoyed your lectures in Cairo, and also lectures about Raynaud phenomena, and that one of in diabetes foot and ankle. All of us actually, as I mentioned, deal with Ilizarov assisted technique. But what I would like is to say, any technique that we use, which is in need for microvascular or plastic, and we can do it by ourselves as an expert in Ilizarov to some extent. So I would like to call it orthoplastic, because orthoplastic, it is not possible in many institutes or colleagues. Even if I found him in my college, in my university hospital, I should rely upon making appointment and waiting, and
yes,
the
yes.
patient may take so long time. So the problem is on the shoulder of the orthopedic surgeon from the start. So
That's why
me and you all in the board in Asami, India, and in Bangladesh, and all other similar countries to teach and learn and train our colleagues, as you mentioned, don't do amputation except at last chance, except if amputation is save life for the patient, as that of the, we can say, Madura foot, or we can say compartment syndrome or something like this. But doing amputation for something which be reconstructible is worth to try.
Yes, thank you very much.
So, any more questions, or shall we move to next talk? Yes, sir.
Yeah. Okay.
Just
stop share. Okay.
So, thanks, Fadel sir, for a wonderful talk with a wonderful interaction. So, next, sir, I need to introduce yourself, sir, please. Yes, sir.
Yeah. Should I stop sharing?
Yeah, please, sir. Please, sir.
I think I stopped. Yes.
No, thank you. Can you hear me, sir?
Excellent.
Yes.
Thank you, sir. So today our next talk is by our loving President, Dr. Rajat Agrawal, sir. He's presently President of Asami, India. He is a gold medalist in MBBS. After completing his MS in 2007, he went for Deformity Fellowship in Bombay Hospital under Dr. H.R. Junjalwala for 6 months. In 2008, he went to US to Dr. Joe Paley for 1 year fellowship in limb lengthening and reconstruction. In 2009, he joined Government Medical College, Gorakhpur, as Assistant Professor in Orthopedics. In 2016, he did fellowship in Ilizarov and Kurgan, Ilizarov Center, Russia. Since 2011, he's been working as a senior orthopedic surgeon in Agrawal Orthopedics Hospital, that is A Hospital, and Institute Gorakhpur. Is currently president of Asami, India. Has published many national and international articles. Recent one in 2022 on Cobatus virus in JPO British. He trains 4 fellows every year in limb lengthening and reconstruction. So with this, I'd like to request Reza to share his talk. Thank you, sir. What you, sir?
Yeah, it's visible.
Yes, yes, sir. Please go full screen, sir.
Okay.
Yeah.
So welcome everyone. My talk today is management of compound fracture tibia, primarily by Ilizarov, and the technique we call as plating assisted fixator in compound fracture tibia. This is a very basic talk for Ilizarov surgeons. I think almost every Ilizarov surgeon knows it. But more importantly, this topic is very important, especially for the young passing out orthopedic surgeons who have to manage compound fracture tibias, maybe as a first case in their private practice. And if you deal your compound fractures primarily with Ilizarov, you can get really wonderful results. And more importantly, you can avoid many complications, which may not be good for your practice. So this is a case of infected non-union with a discharging sinus. A 25-year-old male came to us in our OPD, a very common scenario. The patient which we get in our OPD. It was a case of a compound fracture tibia. Somebody did a primary nailing and it turned it into an infected non-union, and patient came to us. Now we removed the nail, we did a thorough debridement, we did a bone defect was there, we did a corticotomy and lengthening, and finally we were able to achieve union. Okay, that's a good result. But that's not the point. The point is why this happened. We could have prevented it in the first place. The patient suffered a lot with multiple surgeries, with a lot of money. It would have been prevented in the first place. We must understand that nailing is a good option if the patient presents early and there's not much of communication. But there is a disadvantage of chance of spread of infection and damage to the endosteal blood supply. What if the patient comes after days, which is very common in our country? Many times the patient comes after 3, 4, 6 days. And on the side, you can see there is an unhealthy discharge. You're not very comfortable in putting an implant inside, and there may be comminution many times. Most of the surgeons currently use a temporary external fixator and a secondary nailing or a plating. This leads to multiple surgeries, and there is always a high chance of infection and non-union. Ilizarov, usually as an option, it comes last in the list. Why? Usually it is reserved as a salvage procedure when all other treatment options fail. Why not do it in the first place? But still, most of the young surgeons are hesitant and they are not much interested in Ilizarov, unlike replacement or the scopy surgeries. So what is the problem with Ilizarov? Actually, there is a problem with Ilizarov. There are actually two problems with Ilizarov. The first problem is the reduction. In Ilizarov, usually we do percutaneous indirect reduction technique. We all are comfortable with an open reduction and internal fixation of the fractures. And doing a percutaneous reduction in the operation theatre of displaced fractures is quite difficult. The second problem is with the frame application. Usually in various Ilizarov workshops, we are taught to apply frame on a normal bone. But it's difficult to apply the frame during the operation theatre in a displaced fracture. So how to solve this problem? Why don't we do open reduction and internal fixation only, which we do in every trauma case, which are not compound? And then we make it as a normal bone. Then we apply Ilizarov on it like a normal bone we are taught in a workshop. And then we remove the plate. Well done. This technique we call as a temporary plating or a fixator assisted plating. It is technically very easy. There is obviously better reduction and there is a decreased rate of malunion and non-union. Now let's say a 28 years old male came to us with a compound fracture tibia. We did a debridement, a thorough debridement. We identified the muscle, the fragments and fixed with the K wires. And then we applied a plate, which you normally do in any case which is not compound. Now we temporarily closed the skin and made it a normal bone. And then we apply simply a fixator over that, an Ilizarov fixator. You can always check the vascularity with a Doppler machine. Even the Ilizarov can help you in soft tissue traction for a gradual and controlled skin approximation to avoid the necrosis. This is very important in tier B and C cities where the plastic surgeon is usually not available at the time of the surgery. Then you can take the help of the Ilizarov also in managing the soft tissues also up to an extent. Now this was the final frame. The Ilizarov was applied. The skin was approximated. Now this was the post-op picture. You can see the fracture is properly reduced just with the help of 2 lag screws. The plate is removed. A fixator has been applied. There is no major implant inside. The chances of infection are less. Bone is properly reduced. In one surgery, you have managed everything. Actually, you must understand that especially in private practice, number of surgeries is very important for a patient. A patient hardly affords 2 or 3 surgeries. In fact, if you will say in the initial stage that you may be having 3, 4 surgeries, patient may run away. So with the Ilizarov, this is a very good advantage that in one surgery, you manage the soft tissue, you manage the correction, you manage the union without any chance of infection. A very simple case, a 10-year-old boy came to us with a compound fracture tibia. See, we just applied the plate first to reduce the fracture, made it a normal bone, and just apply a 3-ring simple Ilizarov fixator over that. See, this is the intra-op Shyam picture. You can see with the plate, we can achieve a proper reduction, which is difficult to achieve if you try to apply Ilizarov percutaneously. And then we just reduce the fracture of the plate and simply we applied a fixator. And then we remove the plate and we close the wound. This is the post-op picture. No implant inside, which means the chances of infection is very less. Fracture is properly reduced. And with Ilizarov, you can start walking even with day one. Everything done in one surgery. Even as I said, you can manage the soft tissue defects with the Ilizarov. Now, this is an aluminum plate with a stopper wire. You can put it and you can do a gradual skin closure, and many times the wound heals without doing any plastic surgery again. So some of the very basic frame application tips, whenever you're going for a compound fracture tibia, you should have a knee and a heel support, which we made with the Ilizarov instrument. It helps you in having a 360-degree view and a working space. The first and the most important thing, always apply the first reference wire in the C-arm, which has to go parallel to the knee joint. Otherwise, it may lead to a varus or a valgus deformity. This is the first wire, which has to be under the C-arm, and the second wire, which has to be parallel to the ankle joint, and you have to fix the frame parallel to the tibia and the fibula so that there is no procurvatum or a recurvatum deformity. Now, these cases in X-rays, they look very simple. These are simple because we applied Ilizarov in the first place and we didn't wait for the complications. So middle open 1/3 fracture tibia, we applied Ilizarov, another middle 1/3. Like there, we have a series of more than 500 cases. But these look simple because that's the main goal. You let it be simple. Keep it simple. You don't let the complications happen. Middle 1/3 fracture, segmental fracture tibia, 1/3 committed fracture tibia, 1/3 committed fracture tibia, badly committed fracture tibia. See how beautifully the fracture united. Another very badly committed fracture tibia, another fracture tibia managed with screws, another fracture tibia managed with olive wires. In fact, in cases of infected non-union also, you just take out all the hardware, open the fracture, debride it, reduce it properly, and just apply an Ilizarov frame over that. You will get good results. Lower 1/3 fracture tibias in children, you can just fix it with the K-wire. If it's a child with not much of a length of the bone, even you can apply in the femur. In fact, we did a thorough review of literature, and we found there are quite many articles on Ilizarov as a primary treatment for open fractures. There are many surgeons who are doing this, but what the difference we found between these publications and our technique is most of these publications, their recommendation was that these type of surgery should be done by Ilizarov surgeons, and they did a percutaneous entire to addiction technique. That's why they recommended Ilizarov surgeons. And in many articles, they did a temporary fixator, which was converted to Ilizarov after a mean of 8 days. Now, that's the difference. What we recommend is we recommend this surgery to be done by every young trauma surgeon who don't want to be an Ilizarov surgeon even, but for managing of compound fractures, you do this technique. You just open, reduce, and temporarily internal fix, and then you immediately apply the Ilizarov application, and just one surgery, and it is done. In one of the review, we found even Ilizarov is not even considered in compound fractures. They did a comparative study on the ream nail, unream nail, external fixator, plate fixation. Ilizarov is so less that it's not even considered in doing the comparison studies. Now, this is what we are trying to change. Now, as we talk about the advantages, as I said, usually for the management of soft tissue, we go for a delayed primary closure or a slip thickness skin graft or flaps. But Ilizarov can even help in the management of the soft tissue also. With Ilizarov, obviously, we can correct any malalignment later on in the post-op period with the help of olive wires. One of the very big advantages, it avoids multiple surgeries like temporary fixator, the nailing, then bone grafting. These all are avoided with Ilizarov. There is always a less chance of delayed union and non-union, because with Ilizarov we can go even for a gradual compression later on, which is not possible in any nailing or plated cases. And the best part is the chances of infection are very less, as you're not applying any internal hardware. Now, Ilizarov is famous as one of the only treatment options to manage the bone defects. Later on, if there is a bone defect, you can always manage it later on. Now we talk about the uniplanar fixators or Ilizarov. Now, this is totally a surgeon's choice, whether you want to apply an LRS or a rail fixator or an Ilizarov fixator. It depends on which fixator you are trained on. If applied properly, every fixator will give a good result. The only thing is they applied it properly. If we compare the recent hexapoid devices like the DEFWIS or the TSF or SUV, you must understand that Ilizarov is our own tried and tested Maruti, which is sold for so long, and usually you don't get fail with it. So what we recommend is to first, as with any other driving, you first learn driving on a smaller car like a Maruti, and later on you can try the latest gizmos, currently the Mercedes and the BMW, which are supposed to be the TSF or the DEFWIS or the SUV of the current scenario. But it's always better to first learn the driving, first learn the technique with an Ilizarov, and later on you can choose whatever you like. Now, finally, what we recommend for every orthopedic surgeon who is not an Ilizarov surgeon, we don't ask you to be an Ilizarov surgeon, but you must have Ilizarov as an armamentarium in your surgical procedures. You must understand that our bulk of cases are trauma, and open fractures are a significant part of it. You don't need to be an Ilizarov surgeon, but just learn the basic Ilizarov for fractures and apply Ilizarov instead of a temporary fixator. Avoid multiple surgeries, be aggressive, and do best in your first shot. So the take-home message is, don't wait for the complications to happen and expect Ilizarov to do magic. Do Ilizarov in the first place when things are still simple, what we call as preventive orthopedics. In future, in one of the talks some time back, I heard a Japanese surgeon who were trying to invent betadine-coated implants or plates, which we can apply in compound fractures, and we don't need to remove it. So unless these type of implants come in the market, try Ilizarov. Thank you. Thanks a lot.
Thank you, sir. Thanks a lot for a wonderful talk on Ilizarov. So, do you have any questions, sir? Fadel, sir?
I think he's mute.
Fadel, sir, can you hear us?
Yeah, I can hear. Yes,
I hear you. Yeah.
So, any questions, any comments from your side?
I have questions, but I am waiting usually to listen for our colleagues first, especially trainees. So I keep myself for last one.
Okay, sir. Right, sir. So, sir, how many cases you have been applying plate in this compound fractures? What is the ratio of these cases, sir?
Actually, if it's like a grade 3, when it's usually more than 10 centimeters and you can see the fracture in front only, right, then it's much better than to try to fix it percutaneously and reduce it. If you have seen the fracture in front and with a soft tissue damage, it's better to just apply a 4 or a 6 hole plate, a very small plate. You don't have to strip the periosteum even. Just apply the plate and fix it and reduce it as we do in any other fracture. This makes the surgery a lot easy, especially for the young surgeons. We must understand, we have the fracture in front and we are trying to reduce it with the wires. So it makes logically sense. You just reduce it in front and then you apply the Ilizarov. For very, let's say puncture wounds, if you can reduce it with the percutaneous wire, is fine. But many times we have seen it's a badly committed fracture and lot of displacement, we just give a small incision and we reduce it. So what we recommend is, if it's a grade 3 fracture, more than 10 centimeters of open injury, you should definitely go for a plate. For a lesser amount of injury, if you can reduce it, that's fine. But if you can't reduce it, it's better. There's no harm in opening it, reducing it, and then closing it again.
Right, sir. Fadel, sir, please. Fadel, sir, raised hand, sir. Please, sir. Sir, your comment, sir.
Myself?
Yes, sir. You raised your hand, sir.
Yes, I raised, but if no question, I have a question.
Please,
Okay?
please do, sir. Yes, sir.
Okay. Thank you so much. Excellent suggestion. And actually, you have now, you can say, assisted plate as an assistance. So you buy a new assistance.
Yeah, actually,
paying.
we have heard of fixator assisted plating normally as a procedure, but this is a new term.
Yeah, you save money for one assistant.
Yeah.
Actually, if doing assistance by yourself or production with tail fixation, you save time, you save traction for the vessels, you save traction and manipulation, which is harmful for the open condition of the soft tissue and the bone. Straying or taking the distal part or the leg, which is fractured, by doing traction or doing manipulation, rotation, or flexion, extension, it is so harmful for the internal structures of the leg. So it is, I'm with you actually, to do in reducible or non-reducible fracture easily by traction, and in those cases of suggested invagination of soft tissue in between bone to do open reduction. In this case, I safeguard many soft tissues from harmful, because vessels, nerves, and every soft tissue amenable for damaging by moving the distal part or the fracture part, right or left or above or down or flexion or extension. Those soft tissue could be damaged or maybe torn by these methods of strongly trial of reduction. This is my appreciation for your technique from this point. The other point is that a question. Did you find in some cases that you find an infection in the site of doing this plate intraoperatively, and later on you found infection in the same area, even late after 2 or 3 or 4 weeks, or you didn't meet any cases of post-removal of the plate infection?
Actually, the plate site is the same as the compound fracture site. So it's hard to tell that because in compound fractures, infections will always happen in a percentage of cases. So as you're saying, I'm thinking, because it's difficult to say whether the infection happened because of the compound fracture as such, or because we applied a plate. But because we applied a plate, just let's say for 10 minutes, we just applied for a reduction of the fixation, and we removed it after 10 minutes as we applied the frame. So we don't think so that just by applying a plate for 10 minutes may lead to infection. Only thing is, if we are doing a lot of periosteal stripping, then the chances of infection and dead bone may increase. So we try to apply a narrow plate with minimal soft tissue stripping, so that we don't do any more damage to the soft tissue. That's the main thing we always try to avoid.
Excellent, actually.
Thank you.
Very good idea.
Yeah. Akansha has a question. Akansha,
Dr. Bari, you are mute.
Bari sir, please unmute, sir.
Dr. Bari, you are mute. Please unmute yourself.
Okay. Can you hear me now?
Yes, sir.
Yes, listen. Rajat, take it easily, what I will tell. Professor Ilizarov was always, I will just quote the Ilizarov. Professor Ilizarov was always fond of saying, no surgeon is justified to do any reconstructive surgery by my technique unless he has got the competent idea regarding the technique and the apparatus. This is number one. Number two, soft tissue lengthening is a combination of a stretch and regeneration. Before Ilizarov, rings were invented by lots of the orthopedic surgeons. But the biological parameters that was given by Ilizarov is still everybody all over the globe is using the biological parameters of Ilizarov. Even tailors, special frame, ACV, everybody. Three-dimensional correction, compound fracture. In my life, I have not faced any problem by doing the three-dimensional corrections. What is the advantage of Ilizarov? Multi-level, multi-correction, any kind of deformities. And open fracture, why I will go for the plating if I can correct it by Ilizarov technique? You just tell me. This is the violation of the rule of the Ilizarov principle. This is the violation of the rule of the, you can do it, but do you have the publication of doing that one? Lots of other publications you have shown me, but I have not agreed. In my life, I have till today, I have done 42,000 cases in my life since 1982 from my residency. But why I'll go for, if I can correct this one, why I'll go for plating that Professor Fadel mentioned? You just tell me. Can you hear me?
Yes,
hello.
Sir.
My question is that if I can correct the compound fracture, Gastilo 3B, even that, before that, here shown only this one. Why you'll go for the plating? You just tell me the for reduction long, Gastilo 3B or 2A, your why, just give me the answer. Why you will go for plating? If you can correct it three-dimensional by olive, any correction, any deformity, why I'll go for then plating? Just give me the answer. Then you are removing the plate. By on the table, I can correct this one. I can correct this one on the table. And everything must be done gradually. This is the principle of Ilizarov. Okay. So don't take it otherwise. Yes. My observation is open fracture, assisted plating you can do. You may invite the infection. The question was raised by the Professor Fadel. How many infection cases you have treated? Open means that is infected. Infected what? Most of the cases in open case. Even then you have shown your case, interlocking nail 1 and 2. See, interlocking lane by Shyam control, even then infection you are getting. Open fracture by plating. Periosteum, when open fracture, periosteum is hampered. Disturbance of the periosteum. When you are putting plate, you are just reducing and then applying Ilizarov. Why? I don't understand. I'm not agree with you. This is my opinion. Please don't take it otherwise. Thank you very much.
No, sir. Yeah, sir. Let me speak. That's the point I want to emphasize, which I stated at the first of my slide. Sir, you can reduce every fracture with Ilizarov without applying a plate. But what about the thousands of surgeons who are just passing out? They don't have any idea of Ilizarov. They just know how to apply a very basic Ilizarov fixator. And I have seen many cases in which Ilizarov was applied, but the principles were not followed. The fracture was not reduced. Just for the sake of the Ilizarov, they applied a Ilizarov, which lead to really bad name of Ilizarov for centuries, for a decade. People just had applied an Ilizarov, fracture was not reduced, and they thought that Ilizarov by itself will do everything. If you apply the principles and you reduce it properly, which can be done by every experienced Ilizarov surgeon, this technique is not needed. But what I have seen that either they don't apply Ilizarov or they apply Ilizarov, a really bad Ilizarov, and they apply a plate or a nail, which gives to disastrous results. So unless you are trained in reducing the Ilizarov, reducing the fracture by Ilizarov itself, and you can see the fracture in front of you, with already the periosteum has been stripped off. Then instead of applying a bad Ilizarov, it's better you just reduce it and apply a proper Ilizarov. So that's why I said this talk is not for the experienced Ilizarov surgeons who can reduce the fracture beautifully by Ilizarov. This talk is for the young surgeons who are applying a plate or a nail and giving disastrous results, or applying a Ilizarov, which they have learned 1 week before in a workshop to apply Ilizarov on a normal bone, and there is no reduction, and then they blame the Ilizarov later on that it doesn't work. Yes, sir.
Okay.
Right. So thank you.
What about the Professor Fadil's comment? I want to listen it again.
I think Dr. Rajat explained a good idea about whose are not efficiently trained in Ilizarov. For this,
then they should not apply Ilizarov.
Yeah, and but then they're applying a plate or a nail, and it's disastrous to the patients. Because the surgeon will do the surgery. They will not refer it to another surgeon. They will be doing the surgery anyhow.
Even then, my opinion is that Ilizarov is still you have another, you don't take it otherwise. See, 1952, Professor Ilizarov invented this one. Till today, 2023, the biological principles, who has given that effect of Ilizarov? Only playing with the wires. Even lot of the orthopedic surgeons doing hybrid, telling Ilizarov, this is not Ilizarov. You're putting the shunts and at the same time putting the wires. This is called it. This is not Ilizarov. This is not Ilizarov. But the Ilizarov, whatever I have learned from that, and I'm doing in my life with playing with the wires, except in the upper of the TV. You can do whatever you like, but if you want to follow the principles, that's why Professor Ilizarov always telling in his book written in Russian language, I'm telling you in English, no surgeon is justified to do any reconstructive surgery by my technique, unless he has got the competent idea regarding the apparatus and the technique. This is the principle. Violation of the rule you have done, this is okay, but this is the violation of the rule of the principles of the Ilizarov. This is my message, what I have learned from the Kurgan Center and what I am doing. Thank you very much.
Yes, sir. So totally agree with this. This is just during the learning phase until you learn the Ilizarov, but we still recommend that you apply the Ilizarov. But instead of applying a very bad Ilizarov, this is just during the learning phase. Once you have learned it, you will not need it.
Yes, sir. For those who are not confident, you can apply.
Yes,
thank you. Thank you, sir. Akansha has a question. Akansha, please.
Good evening, sir. Sir, that was a very nice talk, very informative. Just have one question, sir. In the pediatric skeleton for a middle third compound fracture that you showed, you had applied some K-wires. So I just wanted to know what stage, like after how many weeks do you remove the K-wires, sir?
Actually, when you applied the Ilizarov, think that the fracture is stable, you can just remove it then only. But if you think that there is a combination and the fracture is not stable, you can leave the K-wires, because the K-wires will hardly do much harm for infection. So you can leave the K-wires, and once the fracture is united and the frame and the fracture is united and the bone and wound has healed, you may remove it later when you remove the Ilizarov frame only.
Okay,
or sometimes there is loosening of the wires and the wires are coming out from the skin, then you may have to remove it earlier. If you see that the wires are protruding to the skin and causing harm to the patient, you may remove it earlier, but later on, otherwise you can just remove it with the Ilizarov frame also.
Okay, sir. And another question, sir. Sir, just wanted to know what is the minimum length of the plate, like how many hole plate do you use, sir, for fixing the preliminary fracture?
Actually, I try to use a minimum hole plate, maybe a 4 plate, because we have to apply wires also. And we have the principle that the wires, as near they are to the fracture, the frame will be more stable. So we apply a longer plate, we have to apply a wire outside the plate. So our wires may be a little far from the fracture. So many times I just apply a 4-hole plate, 2-hole above and 2-hole above, because it's just to reduce the fracture and to fix it for 10 minutes. So you don't need a longer plate as the principle in trauma, that you need a long plate. You may just be fine with a 4-hole plate. Yes.
Okay, sir. Thank you, sir.
Thanks, Akansha, for question, and all the best for upcoming course at Hyderabad. Yeah. So now I invite Dr. Mohit DHINGRA from Rishikesh. He recently did a very wonderful course at Rishikesh AIMS. He has a case discussion. Dr. Mohit DHINGRA, are you there?
Yes, I am there.
Yeah, yes, please. Over to you.
Good evening, everyone. Actually, very nice talk, very good interaction. And as Professor FADEL said, every case is, your case is yours. So you have to deal in a very specific way. Shall I say my screen now?
Yeah, please. Go to the first slide, please.
Yes. Okay, my case is not of Ilizarov, but it's a newer device what we are having in the market. It's alpha fixators, articulated limb fixation devices. I've started using this device since last 1.5 years, and I'm having good results when I'm using it in femur. So I've restricted myself to using this only in femur. This is my case. He was a young male, 22 years male, who had come to us in emergency. He had a grade 3B open fracture and classified by US 33C3. And he had this injury in June 2021. He was applied as the principal says that you do an early debridement, reduce the joints well, and apply an X-fix. So he was applied X-fix. After debridement and applying X-fix, we had actually closed the wound, and we had fixed this intercondylar area with the help of CC screws and applied external fixator. The debridement was followed by medial gastrocnemius flap, which was done some 20 days later than the primary surgery, and later on, genicular artery profitator flap was again done by a plastic surgeon. And in the meantime, when we were applying a flap, we had put semen beads in the wound because he had developed infection in that area. Now, these beads were removed in a locally with the and the wound was again debrided, and this patient was then referred to me for further treatment. Now, this was the condition of this patient when he had come to me. He had a shortening of approximately 10 centimeters. There was a wasting in the thigh. The skin over the fracture was puckered on the medial side. There was a deformity in the thigh. It's a small ulcer also present of 2 into 2 centimeter with a scar. Palpations, there was no tenderness, as usually we don't have much tenderness in non-unions. So now there was abnormal mobility in both the planes. Distal pulses were palpable. Now, if you see the movement, there was absolutely no movement at the knee. He just had the 15 degree of jog of movement. Probably that was happening at the fracture site, not at the knee. And extension was restricted. He had a shortening of approximately 10 centimeter in the femur. This was his X-ray when he had come to us. There was a huge bone gap. The intercondylar part was reduced by the primary surgeon and fixed with cannulated screws. And this was since when he came to us, all these pins were all infected. He was pouring from the proximal pin side, so we had removed the X-fix at that time and gave him some pin rest. Then we operated this patient in March. So when we did a planning for this patient, we had many problems with him. for the problem first was the non-union because there was no activity at the fracture side. He had a lot of shortening. There was a lot of soft tissue contracture also present. He had loss of knee movements, and there were previous broken pins present in the femur, and obviously putting an internal implant here was out of question because he had soft tissue compromise, and also there was, if I had gone for a internal fixation, he had a lot of chances to have infection. So keeping all these 6 points in mind, I thought what best I can do with this patient, because I can't cover all these things with one definitive surgery. So knee movements were out of question for me. Yes, the soft tissue contracture I could have managed by releasing all the scars. Shortening I could have managed with doing a corticotomy and lengthening. Non-union I could have managed doing a good debridement and freshening of bone ends. So all these things I would have done with the help of an external fixator, and here what I used was alpha fixator. So alpha fixators, nothing like, they are like LRS fixators, where we use LRS pins in the bony fragments. Now we have this, we can actually bypass the knee, and we can get some fixation in the tibia as well with this kind of fixator. And the primary side, what I did was I had debrided the bony ends. I primarily docked the bony end and did a corticotomy above. Now, in doing this debridement and docking the bone, further 2 to 3 centimeter shortening was produced. So now I had a shortening of approximately 13 centimeter in this patient, and I needed to produce 13 centimeter of bone in order to make this limb equal to the other limb, and also achieve union at this fracture site. So this was his post-op X-ray. You see, I had 3 pins in the proximal segment. I had a corticotomy there. I had docked the primary site, put 1 pin into the distal fragment of the femur, and put a few pins in the tibia, and made the frame. So this was his X-ray, which we usually get after 15 days to see if this corticotomy is working well or not. And further X-rays were done in further coming months. And if you see, the fragments have started moving away from each other, and we are having good regenerate which is being formed. This is the X-ray of May 2022, and it was approximately, we did in April, so it was approximately 2 months after the primary index surgery of corticotomy. Then this is X-rays of August. You can see the degenerate being formed there. Now we went on, kept on distracting this fragment till we attained the equality in both the limbs. He had few problems in between because of the pins. I had to change 1 or 2 pins in between because he was developing some infection there. I had to change those pins, but yes, we somehow passed that time of that keeping external fixator on, and until this was the X-ray of November 22. And this is clinical photograph where we had achieved the equality in both the limbs. And this is his X-ray at February 2023. This is his video. Once he had achieved equality in the limbs, we started making him walk on with the help of walker, putting weight on these bones so that his bone quality improves. Because the problem what I was facing was when I put the pins into the distal femur or the proximal tibia, the hold in the distal femur was not as good as I was getting hold in the proximal part of the femur as well as in the tibia. So my anticipation was that this bone quality should improve. Once I had achieved this regenerate, I had passed the external fixator time and had achieved this kind of regenerate. Because the regenerate which was produced was approximately 13 centimeter, very long regenerates, and it had a very high chances of fracture. Now, again, I had a problem because putting in just to protect the regenerate, either I have to keep this external fixator for a long time or put an internal implant there. So putting a plate on this area was difficult because the soft tissue around the knee was not good. So I thought of putting a tense nail. I took the fixator out and put a tense nail just to provide some kind of support internally so that we can avoid any bending of this region rate, the long region rate. This is his video which we took when we had put this tense nail. He started walking with a walker. He was putting weight on the limb, and he went home. Now, what happened is, few days later, he came to me. He stopped following some of my instructions of keeping some protection for some more time, and a few days later, he again came to me with a pain in his thigh. He didn't tell me what had happened, so I got an X-ray done, and if you see here, there's a small fracture which has happened in the region rate. So rather than putting any further plaster or all, I just asked him not to be a weight and put a brace on him. His distal part was all united. If you see, this distal part is good, united very well, but the proximal, there's a small fracture which has happened there. I gave him rest for around 1.5 to 2 months. He came to me a few days back, and I took his photographs. He had no limb line discrepancy. This is his video now, where he is walking with the help of stick now. He definitely has some amount of varus. I can see some amount of varus in the femur, but we still have to wait for further for his region to get more stiff and bear his weight. We had published our results of 8 cases of this alpha fixator, where we have used this fixator for a gap on femur. Now we have done more than 12 cases, but when we started writing this paper, we had included some 8 cases in this study. And this is this patient who had a gap of approximately 12 centimeter, and post-op limb line discrepancy was around 7, and regenerate length what we attained was around 14 centimeter. Overall, we got good functional results of Asami and good bone results. So just to summarize, distal femur fractures are relatively common, and vast majority of these fractures occur with open injury, as an open injury. Adequate stabilization which is required here, because what we have is we have a poor bone stock distally. If this is open fracture, and if we have to put a Ilizarov, or we have to put a LRS pins or alpha fixator pins, then the amount of bone what we get here in the distal fragment is quite less. So the primary goal of the treatment of the non-union is to provide an environment in which new bone can be created, or by establishing and maintaining the mechanical stability and biological conditions that are conducive to new bone formation. So since the distal femur has limited bone stock, so we need sufficient bones for sufficient pins to get good fixations, and that is why when we are using the alpha fixator, we are augmenting the fixation with the help of putting pins in the tibia down there. The presence of knee stiffness along with the non-union complicates the situation. The selection of particular technique is based on the type of non-union and whether or not the alignment of the fragment is adequate. So to conclude, alpha fixator is a safe and can be considered as an alternative to Ilizarov and LRS, provided adequate distraction osteogenesis, less neurovascular compromise due to pins, better patient tolerability and user-friendly distraction. And in the presence of soft tissue infection and damaged plastic surgery procedures can be carried out with this alpha fixator, which I think is difficult to carry out with Ilizarov fixators. Thank you.
It's a wonderful case. Any questions, sir? Dr. Mohit, why didn't you put the brace in the first instance after removing the fixator?
Yeah, actually, I had advised him a brace to get this brace made from a prosthetics. So he thought, I mean, he had no pain, so he himself got some lazy on it. So he made this brace, but later once he had this pain in the femur and a small fracture had developed by the time.
Yes, you have to be cautious because it was such a long lengthening.
Yes.
Rajesh sir, Bari sir.
It's a very difficult case, of course. Can you hear me?
Yes,
Yes, sir.
Yes, sir. Of course, difficult case. He has done well, but still, question arises. After treating with this alpha fixator, uniaxial cannot be comparable with the multiaxial. This is my number one. Number two, distal femur fracture. You could easily do it by only multiple cures with Ilizarov fixator. Distal femur. It is not difficult to put the Ilizarov fixator. Alpha fixator cannot be comparable with Ilizarov fixator. Never. I know the alpha fixator. What is alpha fixator? And by treating, you have done a lengthening very good. But see, the problems arise. Whereas, number one, varus deformity. Number two, knee stiffness. You should have to go for the quadriceps plasty. But it is difficult here. Varus deformity you have invited, and refracture you have invited by using this alpha fixator. Lengthening, by doing any kind of fixator, you can go for LRAs or alpha or Ilizarov. But this kind of distal femur, better to go for Ilizarov. This is my opinion. Distal femur, multiple fracture, multiple K-wires you can handle with this. And at the same time, if you put the Ilizarov in the distal femur and the proximal tibia, go for ASD, articulated hinge distraction, you can supple the joint. You can moment, you will get the little bit moment. And lengthening also easy with Ilizarov fixator. Most of the surgeons are saying Ilizarov is cumbersome in case of femur. Cumbersome for the surgeon, not for the Ilizarov surgeon. The man who knows how to apply the Ilizarov surgery in the femur, that is not cumbersome for the patient. I tell you truly, that is in my practice life, I see whenever you don't put the fixator nicely, not only Ilizarov, any kind of external fixator, if you violate the rule, then you face lots of problems. And here, these are problems. Even then, you lengthen, you've done a quite good case, very difficult case. Thank you very much for you showing this case. Okay.
Thank you, sir. Thank you for your advice, sir. Thank you. It was really nice to have words from a learned person like you. Actually, there was some problem of soft tissue compromise. So that is why initially I had this soft tissue compromise on this medial side. So doing an Ilizarov would have hampered for any plastic surgery procedure if would have required plastic surgery procedure along with doing an Ilizarov. So that is why I went ahead with the unilateral fixator, sir, in this case.
See, again, theory of Ilizarov. Soft tissue lengthening is a combination of stretch and regeneration. That is the theory of Ilizarov. Soft tissue lengthening is a combination of stretch and regeneration. This is the theory of Ilizarov. Even very big gap, gradually you can stress. Ilizarov, this is a tissue genesis, dermatogenesis, neurogenesis, myogenesis, osteogenesis, everything, tissue genesis. That's why Ilizarov is a very good thing. A lot of the surgeons are thinking that Ilizarov only putting the words. No, you must think about the law of tension and stress that Professor FADEL showed. Whenever I put Ilizarov, I keep it in mind. What is the law of tension and stress? Slow and steady traction on a living tissue creates stress, which is metabolically activated both in biosynthetic and proliferative pathways, depending upon the load and the function. You see, in 1983, Professor Ilizarov showed 330% vascularity. This is not a matter of joke. No other alternative fixator gives this kind of this. Ilizarov 330% shows in animals, in dogs, in cats, everywhere. This is written in the Ilizarov Center, Animal Center, 330% vascularity. This is proved, and everybody knows this one. That's why I'm passing this kind of message so that the young budding orthopedic surgeons, they can learn. Thank you very much.
Thank you, sir. Thank you.
Yes, sir. Thanks a lot for valuable comments. Brother, sir, any comments? Please unmute, sir. Please unmute, sir. Please unmute.
Yeah, I actually agree with Dr. DHINGRA that maybe because of the soft tissue problems, because many times we have to deal with the plastic surgeons also. And I have to say that the plastic surgeons hate Ilizarov. Like whenever the plastic surgeon comes to me in a case of a Ilizarov patient, and I just say, oh, Ilizarov, usually he tries to run away. So my plastic surgeon is okay because now he's very well versed that in KM, if we are coming to our place, most probably it will be an Ilizarov case only. But yes, for plastic surgery and for the soft tissue options, yeah, so many times we have to go with a alpha fixator or a monorail fixator. So I think, as Dr. Dhingra said earlier, that it all depends on the patient. The patient is yours, and you know what's the best for the patient. Yeah.
So, Fadel sir, please unmute, sir.
Thank you for this presentation, dear Dr. Mohit. I didn't actually listen for it all because some few minutes I missed it. But I would like to stress as a basic in my experience that using for the distal part of the femur or upper end of the tibia, or even also the distal part of the tibia, the bone, any cancellous bone, even subtrochanteric area. This cancellous bone, it is not possible to be adjusted or captured securely using screws or shants. It is so beneficial for any surgeon, orthopedic surgeon, to deal with this area of metaphyseal parts by using wires, even upper end of the humerus, even distal end of radius. All these cancellous bone, if you use the wires or the wire technique with a circular frame, or even with a hybrid one, or even for this area of fixation, the metaphyseal area, which may be in the lower end of the femur, around 8 to 10 centimeters. If you use wires in this area, it is so marvelous effect for you for any dealing with metaphyseal area. It gives you many options. Hard, not hard, but we can say that it is stable, not hard. Stable and active and resilient for any biological stress of this area. So I relied upon wiring of any metaphyseal area, whatever. Other things in cortex, you can, if you are early in Ilizarov frame application, you can use shans, you can use rankos, everything. But even those who are using shans and ranko and using even monolateral, in the area of metaphyseal area, near joints, it is beneficial to do this using wiring technique. Even in the basic orthopedic books, not research. Campbell, Roger Green, Roconade Green, even the classic books dealing with this area, even for example, for upper end tibia and in complex problems of fracture upper end tibia, metaphyseal area, Chazikar 5 and 6, and even for the pelvic fractures, the most complicated and displaced type, all this area, if you haven't deal with Ilizarov, at least put a hybrid fixation, or even at least a ring for this area. This is, in my opinion, is so important. Looking for that of putting a docking region in this area also. It is invaginated in a soft cake. So if you lift it, it will be invaginated more and more, and even go for damaging the articular cartilage. The invagination is so strong in this area. So I think in this area, either to leave the frame for a long time enough to have consolidation, or to do bone graft or whatever would be used, augmentation, bone marrow injection, some bone substitutes mixed with autogenous bone graft or something like this. This is 2 points. I think it is general, not for your cases exactly, as I didn't, I missed some few minutes of it. But in my opinion, as a basic rules in dealing with metaphyseal fractures or subcortical or submetaphyseal or juxta-articular areas of bone, and the need for long time for consolidation or addition of bone graft or augmentation by bone substitute and bone graft or even bone marrow injection. Thank you for again for your nice presentation, Dr. Mohit.
Thank you, sir, for a wonderful guidance, sir.
Thank you, sir.
Shall we move to the next talk, sir? I'm sure we already read, sir. Rajat, sir?
Yeah, please. Yeah, we are already like having time.
Yes, we have our young, dynamic, smart Dr. Rajeev, Dr. Colonel Rajeev called from DEHRADOON Army College, Hospital.
So, good evening, sir. Am I visible?
Yeah, please.
Good evening, sirs. I'm Lieutenant Colonel Rajeev Kaul from the Military Hospital, Dehradun, and I thank you for this opportunity. And I'll be talking on limb salvage in the mangled foot with the use of the Ilizarov external fixator. Now, before I start, I have a disclaimer, and that is that the talk is not about the Ilizarov method of distraction osteogenesis. It's more about the innovative use of this external fixator in the management of compound foot and ankle trauma. So this first case is about a 22-year-old serving soldier who was run over by a truck in the wee hours of the night, and he came to us early in the morning with this grotesque looking injury. So on closer examination, you can see a complete avulsion of the skin over the dorsal aspect of the foot. There were no pulsations because the dorsalis pedis artery had been completely destroyed. And luckily, the plantar sensations were intact and the posterior tibial artery was intact as well. Now, yeah, we also noticed that he has a partial amputation of the little digit, that is the 5th toe. And we calculated his MES score to be 7. And we have a couple of scoring systems available to classify this kind of trauma, such as the mangled extremity severity score, the predictive salvage index, the limb salvage index, the Hanover fracture scale, and so on and so forth. But none of these scoring systems sort of give a consensus on these borderline cases, whether you should operate and try to salvage or whether you should go ahead with an amputation. Now, I felt that there are certain clinical keys, such as the local warmth. So if the foot is warm, it is definitely salvageable. If the plantar sensations are intact, it is salvageable again. The capillary refill time and the nail bed capillaries of the nail bed capillaries gives another clue as to the vascularity of the foot. And if you have a handheld Doppler device, it can be extremely beneficial, as you can check the vascularity of the surrounding vessels, such as the anterior tibial and the posterior tibial, which were present in this case. So we took him up for an immediate debridement in the OT. This was done in the wee hours of the morning, so we did not stress on getting the fracture reduction. We just applied an Ilizarov frame like so. It's a very simple design. It's got one ring over the distal tibia, one 5/8 ring over the hind foot, and one 5/8 ring over the forefoot. And the forefoot is suspended from the distal tibia with the help of these two outriggers. A very simple design. Takes about 45 minutes to apply. And I again stress that no attempt at reduction is done at this stage. The aim of surgery is just to stabilize the foot and to optimize the general condition of the patient. So these are his X-rays. It shows a comminuted fracture of the first metatarsal with dorsal dislocation, as well as a complete lateral subluxation of the lesser metatarsals, which is something similar to type 3 Lisfranc injury, a divergent kind of injury. And you can see the X-ray post-op showing just a stabilization without any reduction. So 48 hours later, that's when we take our time to debride thoroughly and then reduce the TMT and MTP joints with the help of multiple K wires. That's the image on the left shows the tibialis anterior tendon stump being identified, which was later tagged and attached to the middle cuneiform with the help of transosseous sutures. And this long intramedullary wire in the first metatarsal to substitute the bone gap. And then we fortify this Ilizarov frame by connecting the forefoot to the hindfoot with these extension plates and adding a number of wires and pins. And you can see in the picture in the middle showing a prophylactic fasciotomy of the fourth and fifth compartments. After that, we covered up the wound with a vacuum-assisted dressing, like so. And this is his intraoperative X-ray showing reasonable reduction of the TMT joints and this long medullary K-wire to substitute the first ray. Notice that we preserve the sesamoids, which will be required at a later stage during reconstruction. So on day 4, when we take off the dressing, we observe a lot of necrosis over the dorsal skin, and this skin is literally begging for vascularity. And that's when we have to call in our plastic team to do an urgent flap. So picture in the middle shows the necrosis on day 4, and the picture on the right shows the extent of necrosis on day 5 to the operation theater. And this is what was done. An anterolateral thigh flap was applied by the plastic surgeons. And again, the versatility of the frame is so it's so good that just by taking out these outriggers, the plastic surgeon got enough space to put the flap, and you can see a very good anastomosis and vascularity being achieved like so. And this flap took up in about 6 weeks. So here he is. Now, of course, the flap and the edges were under tension. So the flap had retracted a bit, exposing the bone defect underneath, but the flap had taken up entirely by this stage. And now we decided to go in for a definitive reconstructive procedure. This is what we did. We harvested a portion of the fibula, which was about 8 centimeters in length, and we shaped it in the form of a metatarsal by rounding the edges. The entire flap was lifted up along the periphery. The fibula was used to substitute the missing first ray, fixed provisionally with K-wires, and later on with internal fixation in the form of a molded 1/3 tubular plate and some small plates, mini plates from the hand system like so, which were applied orthogonally across the fusion sites. Now the aim was to get a completely fused and stable first ray with fusion at the MTP and TMT joints, and also healing across the second metatarsal with bone grafting, which was retrieved from the proximal tibia. So the fusion sites and this non-union site were bone grafted using cancellous bone graft from the proximal tibia. Again, the flap was repositioned after pie crusting to gain some length. This is the immediate post-op picture showing adequate or reasonable reduction. And this is the patient ambulating with the frame on. Now, in a course of time, the fractures healed and the frame was taken off. This is the immediate post-removal X-ray. And this is his clinical picture. These are pictures taken while standing. And that's his functional outcome. He was able to walk unassisted without, actually we did give him a modified footwear with a rocker bottom sole, but he did not require any ambulatory aid. And he also regained some dorsiflexion at the ankle, like so. However, the story does not end here, and the patient came back about 4 to 5 months later with complaints of pain over the forefoot, and we noticed that the second metatarsal plate had broken, probably because of a fibrous union at that site, and there was some loosening of the plate over the TMT joint across this fusion site like so. And hence we had to revise this particular fixation. The tubular plate was taken off and it was replaced by the modified variable angle locking system from Synthes. And we also revised the second metatarsal with bone grafting. And this eventually went on to heal uneventfully like so, with a reasonable restoration of the foot architecture, including the arches. And this was the patient's final functional outcome. Yeah, very similarly, we had another patient who landed up with a similar kind of injury. This time, all the metatarsophalangeal joints had been dislocated. There was no fracture, but it was an open dislocation of all the 5 metatarsals like so. So this is the image after debridement on the left. And very similarly, we put on this simple frame design. So one ring over the tibia, this big ring over the foot, which can stabilize the forefoot and connect it to the hind foot. And with the help of these outriggers, the forefoot is suspended from the tibia like so. And even if it involves the ankle joint, you can apply distraction across the ankle joint, and you can connect the flail midfoot to the forefoot like so. So these are the X-rays of provisional fixation. And of course, later on, this patient, his first toe, the great toe was not salvageable, so we had to amputate that toe. And then again, there's adequate space to apply a skin graft, and this heals up like so. These are his X-rays, and this video shows his functional outcome. So the take-home message is that timely decision-making with the involvement of a multidisciplinary team can often result in a successful attempt at salvage and should be done. And the versatility of this frame can be used to suspend a flail forefoot off the tibia in the presence of forefoot midfoot dissociation, which is often existing with a mangled foot. So thank you very much for your patient listening. I am happy to share that this case report got published in this month's edition of the Journal of Limb Lengthening and Reconstruction. Thank you.
Thank you, Dr. Rajeev. Excellent cases. Actually, these cases, most of the orthopedic surgeons may leave as such after one surgery or all. But later on, as you said, like with multiple approaches and multiple surgeries, we can achieve a really good result. My question, like you use the sesamoid bones later on, because earlier you said that these were to
yes, where did the sesamoids were preserved, and it was underneath the fibula.
Okay, so what did it help, like in union or like in support?
Yes, sir. Since the MTP joint, you want to protect the MTP joint at the time of weight bearing, which is obviously fused. So the weight is taken over by the sesamoids. And it's extremely important that the sesamoids be preserved so that to avoid unnecessary stress transfer to the fusion site.
Okay.
I would like to ask, if I may, Professor Bari and Professor Fadel, what would their approach be to foot defects in the foot?
This is the beauty of Ilizarov that you have done. I must congratulate you. And
thank you, sir.
Teaching from your 2 cases, fantastic. And we are doing these kind of cases. At the same time, you have corrected the Lisfranc joint type 3 very nicely. The beauty of Ilizarov is that you can do the plastic surgery also. And one teaching is that Professor Fadel showed, if you go for the more than 5 centimeter beyond that, go for grafting, that was the failure. And in this case, I could do the mini Ilizarov with lengthening of you had the bone stock of the metatarsal. I can go for the mini Ilizarov distraction gradually, not to going for this more than 5 centimeters that you have taken from the fibula. That was the reason. A second toe, because you have taken the cancellous bone. That was happened. Even then, second time you have done fantastic. I must congratulate. This is the Ilizarov that you can handle, and both the cases. Thank you very much. Okay.
Thank you, sir. Thank you so much.
Fadel, sir. Yes, please, sir. Fadel, sir, please, sir. Your comments.
Thank you. Actually, as mentioned by Professor Bari, very fantastic cases to use Ilizarov in such difficult cases. These are obligated to be dealt with plastic surgeon. I know that you are lucky to have a plastic surgeon to help you in this case. Also, it is amenable if you ask him to start earlier as you can, as it is suggested that the first case, it will be end by this gangrene and the even be not complete gangrene of the dorsal area, but a few centimeters. So it is expected in mangled extremity or mangled foot to have this. So provisionally take care, not for you only, it's for me also, of the degloved skin. Not all the degloved skin considered to be 100% amenable for take off again blood supply. So most of this should be, as you did, followed up. And I think some expectation you can make the debridement and the trimming of this degloved skin, especially for the dorsum of the foot and the dorsum of the hand. All this area, actually, we find clinically and by experience that it doesn't work well in the gloved skin. So if you are not sure that it is amenable for vascularity again, to do courageous debridement, and why not of thinking of what make our surgery and orthopedic surgery and soft tissue reconstruction nowadays, or since 10 years ago, the VAC or assisted vacuum closure technique. It is so simple, and also may help you to maybe not in use urgently for those plastic surgeons, our friends, as we respect them. But if we have no, we can use this vacuum or VAC apparatus, even for cases or for that cases of Dr. MOHIT beforehand. It will help to get rid of the scars post healing, and also give us a very good granulation tissue amenable for simple split section skin graft that all of us can do it simply without need for plastic surgery. This is the idea that I would like to present for you, is to take care of the degloved skin, that it is not seems to be all this area amenable for replantation and the take of blood again. And second comment is to use or rely upon VAC or assisted vacuum closure apparatus. Thank you again, Dr. Rajeev.
Thank you, sir.
Thanks, Father, sir, for a wonderful, and congratulations, Dr. Rajeev, for a wonderful case. You can truly say that Ilizarov is very friendly with any sort of assisted surgery like VAC, flap, or slip grafting. It's done very well. It's very innovative. So, any more comments, Raj sir, or shall we?
Yeah, I think it's time, and we had a wonderful cases by Dr. DHINGRA and Dr. Rajeev, and a wonderful presentation, first of all, by Professor FADEL. So I think our listeners, and especially later on in the YouTube recordings, they will be seeing it and they will be learning a lot. So with us, I thank you to all the presenters for sparing their valuable time and presenting their cases and their talk on this Asami India webmaster series. Thanks a lot. I thank you once again on behalf of Asami India, and good night, sir.
Good night for you all.
Thank you, sir.
Good night.
Good night for you all.
Good night,
Professor
everyone.
Bari.
Good night.
Rajat,
Yes, sir.
regarding the name of the Kurgan professor, I'll give it to you tomorrow. You have mentioned some. Instead of that, can I mention other 3 or 4 names?
Sir, I need just the best ones, whoever are the best ones.
You must take the consent from there. I will just put you the name.
You sir, plus then I